Hi folks. So this is a very short video on urine microscopy covering our colleagues' request on albumin, and a lot of people wanted urine routine in general. So very briefly, right, because urine microscopy is a difficult area. It depends a lot on the technician, the report, and it's actually, things like casts and all are falling away and go actually into the purview of nephrologists. But what we should know are a few things. So first of all, protein, urine protein. Now, urine protein, actually, when you talk about it, can either talk about total protein or albumin. Albumin is a part of the protein which goes through in the urine. So normally, do we get any protein or albumin in the urine in a normal human being? Yes. So less than 30 milligram in 24 hours of albumin is excreted in the urine, and less than 150 milligram of total protein. Albumin being the part of total protein. Now, if there is glomerular disease, then obviously glomeruli are damaged, so protein and albumin get filtered through, so the urinary excretion increases. So that is the primary cause of increase in protein and albumin, and conditions like diabetes and hypertension, CKD, primary glomerular diseases. These are the ones which are the most common causes of increase in albumin in the urine. Now, what is relevant to us as intensivists, as far as urine albumin and urine protein go, I would say it's not relevant to us, because urine protein and urine albumin actually come into picture to diagnose primary kidney diseases, nephrology diseases, hardcore nephrology diseases. So, what conditions can elevate it in the ICU, supposing the patient is normal? So, sepsis can elevate it because there can be some glomerular damage. Then UTIs can elevate it. Then conditions like CHF, febrile illnesses affecting the kidney, stones, so they can increase the urine protein and albumin. So I told you the normal values of protein and albumin. Now, urine dipstick, the report 1 plus, 0 plus, 2 plus is not reliable. If you actually want to measure it, you go for albumin creatinine ratio, what is called ACR. So ACR is albumin per gram of creatinine. It is normalized to creatinine, because you cannot take an isolated value of albumin in a spot sample. Either you do it over 24 hours, which is very tedious. So what you should do is ACR, albumin creatinine ratio, and less than 30 per gram is normal. Anything more than that is abnormal. Similarly for total protein, protein creatinine ratio, and anything more than 150 milligram per gram is abnormal. Simple. So that's all actually for intensivists. And if you really want to look into total protein, you do a 24-hour sample and see 2 grams, 3 grams for nephrotic syndrome and all. This is actually a nephrology test, not really intensive care test. So let's move on to things which are actually more relevant to us. So first of all, I'll talk about color. So color, friends, high color is out. People look at the urine high color, it means patient is dehydrated. That is actually all, the very old medicine now. Yes, if the color is high, think of jaundice. Think of jaundice. And if the color is red, red is very important to us. If the color is red, there are 3 conditions: hematuria, rhabdomyolysis, and rhabdomyolysis leading to hemoglobinuria, and third, myoglobinuria. So how will you differentiate? So you look at the urine sample. If there's hematuria, you get a lot of RBCs, full field or 50 to 100 per high part field. Okay. So that will separate it from myoglobinuria and hemoglobinuria. And myoglobinuria and hemoglobinuria are, clinically distinguishable. You know what is happening to the patient, whether the patient is having hemolysis or rhabdomyolysis. And you can tell the lab also, they can test further and tell you whether it's hemoglobin in the urine or myoglobin in the urine. Sometimes actually if you have, let's say, blood transfusion reaction, so you'll get hemoglobinuria as well as there'll be glomerular damage and you can get RBCs also. But the RBCs are never so much. When the hematuria is causing high color, red colored urine, then you get 50 to 100 RBCs per Hafer field. It's full of RBCs. Okay. Now, apart from this, what are the causes of hematuria and what is normal RBC in the urine? So, up to 3 RBCs in the urine are normal. Menstruating females can have RBC in the urine normally also. So, you should always be aware of this. Then, the common causes of RBCs in the urine in the ICU, one is trauma by the Foleys. When you put the Foleys, the initial samples can have RBCs, and even later on, you can get some if there is trauma to the urinary wall, bladder wall. Then, if the patient has thrombocytopenia, coagulopathy, DIC, anticoagulation, all this can lead to RBCs or some degree of hematuria. All right, and hematuria, if it's persistent, can lead to drop in the hemoglobin also. Now, other thing is, about tranexamic acid. Tranexamic acid should not be given if there is hematuria to control the bleeding, because it can lead to clot formation. It leads to clot formation. It can stop the passage of urine, and there can be hydronephrosis and outflow tract obstruction. That is the one contraindication to tranexamic acid. Very interesting, just for practice, and very important for exams also for those of you who may be doing the exams. Now, moving on to what is the most important thing is WBCs. So, up to 3 WBCs are normal. Anything more than that becomes abnormal. One. Second point, if the Foley is in place for more than 48 hours, you will most likely get WBCs because of local irritation to the bladder wall. So, after 48 hours, if you get some WBC in the urine, does not mean there's an infection. Third, to diagnose an infection or a UTI, you need WBCs, you need a culture positive. Okay. And you should have symptoms. Because again, once the Foley is in place, there's colonization, and you will get a culture positive after 48 hours, mostly. So both you can get WBCs as well as culture positive once on Foley's after 48 hours. So you have to have symptoms. And other thing is, if you want to send a sample, don't send a sample from the bag, you have to send it from the catheter fresh sample. And if you are getting colonization, you suspect colonization, change the Foley's and take a fresh sample. And change of Foley's can sometimes actually help in getting rid of the colonization, though it's not common. Now, what are the causes of WBCs in the urine apart from an infection and catheter? So, the common causes are one, kidney disease, especially tubulointerstitial diseases. They can lead to WBCs, and here the culture will not be positive. These conditions are known as sterile pyuria. Then you can get, because of transplant rejection, because of infections or drugs or rejection in the transplant. Then drugs like steroids, NSAIDs, and many other drugs can lead to pus cells in the urine. Then apart from this, stones can lead to pus cells in the urine, but here you generally get RBCs also. I forgot to mention that in the cause of RBCs. Then very important is if the sample is not from the catheter and there's a sample you're taking from genitalia, from the urethra, it's very important to clean that area before sending the sample, because vaginal secretions are known to contaminate and increase the WBC count in the urine if the area is not cleaned before sending the sample. So this is not common. Most of the people will be catheterized, but sometimes you have to sit. Everybody is not catheterized. So all this should be very clear to everybody. And most important take-home message is presence of WBC in the urine and a positive culture in the urine does not mean UTI. And don't start antibiotics. This is antimicrobial stewardship. This is very common in the ICU, widely prevalent. You get a culture positive, antibiotics are started. And this is not only for urine, anywhere. Everything gets colonized. All pipes and lines and tubes get colonized after 48 hours. Please do not start antibiotics unless there is clinical correlation. This will improve the result in the ICU because resistance will decrease. This is a well-known fact. If you understand a little about antibiotics, you will understand how it works. Okay. Now moving on to the last couple of things. Eosinophils. Now, what is the role of eosinophils in the urine? Anybody knows? So eosinophils have a very peculiar role. They help to diagnose a condition called allergic interstitial nephritis, which is normally a drug reaction. So and this can be because of any drugs, cephalosporins, penicillins, and what have you. Recently, we had the lecture on polymyxins by Dr. Davda sir, and he told us about polymyxins causing this acute interstitial nephritis. And they had the eosinophils, 7% in the urine, and they were diagnosed. And then they gave steroids, and the patient responded. So if you suspect a drug reaction in the kidney, and you should send the urine always. And if you get eosinophil, tell the lab also. You have to tell the lab because generally you have to put a right strain for this, and you'll get eosinophils. That is almost diagnostic because you don't get eosinophils otherwise. And then you're going to give steroids and condition gets treatable. Acute interstitial nephritis induced by drugs. The other condition in which you can get eosinophils in the urine, and again this is very relevant to the ICU, is a condition called atherothrombotic disease. So this normally happens after cath procedures, cardiac cath procedures. So what happens is they do the catheterization, and during this process, atheromas, small atherotic clots are dislodged from the aortic arch or along the aorta, and the shower goes through the circulation. And this shower can go to the kidneys, to the periphery of the extremities, etc. And it can cause a slowly progressive renal failure over the next 1 week, 2 weeks, and gangrene kind of a thing in the limbs. And here again, if you do the urine eosinophils, you will get it positive. This happens, this is not picked up easily. Because cardiac cath is so common. How many cardiac caths are done? And renal failure occurs, and often it is ascribed to contrast-induced nephropathy. So that was about eosinophils. And finally, a word about specific gravity. So you might think I'm talking about ancient things, but these things all help. I've used it all the time. So normal specific gravity is 1.003 to 1.030. Easy to remember. And the specific gravity corresponds to urine osmolarity, or in other words, corresponds to how dilute or how concentrated the urine is. So at maximal dilution, the specific gravity will be 1.003. And at maximum concentration, you know the answer, 1.030. But this has to be done properly. So if you want to check, because all labs don't do urine osmolarity, you have to send it outside, and the report comes after 3, 4, 5 days, by the time the game is over. So you can tell the lab to do it properly, and you can make out whether the urine osmolarity is low or high. A very indirect way. But it works. Everything works. And then there is urine pH. So urine pH, I will not go into it, helps with renal tubular acidosis by and large. That's about it. Okay, there also is really not that much because you have to do the testing and all. So I think, let me see if I missed anything. So that's about it, I think. So there is nothing more than this in urine examination. Yes, the final thing is cast. My colleagues and my students and juniors have often asked me, sir, what is this cast? 2 cast, hyaline cast, 1 granular cast. What is the significance in the urine? So, my dear friends, cast is actually a nephrology topic. It's a very complicated area, and it's dying away. And it needs expertise from the technician. But just telling you very briefly, one or two casts in the urine don't mean anything, whatever it is. RBC cast, if they're there, that means there's RBC in the urine. If there's a WBC cast, that means there's WBC in the urine. If there's a hyaline cast reported, no, one or two casts don't mean anything, like I said. If there are more than that, if there's hyaline cast reported, that means there is dehydration or pre-renal azotemia. And if you're getting granular cast or epithelial cast, that means there's shedding of the tubular epithelium. Just simply. But I don't think you guys will be really interested in this because this is actually a dying art also. People don't really look at cast nowadays, except some very, very good nephrologists who can make out what it is. And some nephrologists even look at the urine microscopy themselves even today. But it's a dying art and this is really a nephrologist area. So, my dear colleagues, that was all about urine. I'm happy to take any questions. Please put them in the chat box. And like I said in my previous video, so please let me know your suggestions, what topics. And if you want ProCal and CRP, I'll be happy to make it. And after that, the other tests, which I think should be covered if you want. So please let me know are tests like ammonia, and then we have ferritin, then we have thyroid function, because thyroid function is not just endocrinologist area. We get mixed edema coma, we get thyrotoxic crisis, and we have something known as sick euthyroid syndrome. So you have to know this thyroid function pertaining to this area. You don't have to know the entire gamut of thyroid function, but a little bit has to be known. So, and there are what else is there? So there are some other ancillary tests. We have covered everything. And sodium potassium is a very detailed lecture taken by me. The two lectures, one on sodium and potassium, up there under fluids and electrolytes playlist by me. So that is done. CBC is done. Platelets lecture is done. LFT is done. And now we have urea creatinine, urine microscopy is done, right? And magnesium, phosphorus, calcium, I will take a proper lecture because that's important. And then let me know, troponin we have covered, BNP we have covered, X-ray we have done, ECG we have done, CTs we have done. So I think the entire spectrum of investigations is practically covered. Ancillary testing is now remaining, like ammonia and this thyroid function test, ferritin, and some other tests. So let me know. Feedback is very important. Keep giving me the feedback because the channel is for you, and we will do things as per your need and requirement. Of course, we also know what is required, but then you also have to give us the feedback. Any feedback is appreciated. So thank you guys. Thank you for being with us and supporting us and with your warm comments. Thank you so much. Bye bye. Take care. See you.